Hi, I'm Evelyn. I'm going to be doing a knee x-ray, and the system that I'm using is a Philips system. It's a DR system, so it's cassetteless. So for the first knee x-ray, I'm going to be doing an AP, and that technique is going to be about 65 at 5. So now I've already gotten my requisition. I've already put my, I've already selected my patient on the system. So now I'm going to go get my patient. Hi, Miss Maxwell. I'm Evelyn. I'm going to be doing your knee x-rays today. Is there any chance that you could be pregnant?
No.
Okay. And then can I get you to please confirm your whole name and your date of birth?
It's Jacqueline Maxwell, 5/14/1990.
Okay. And what brings you in today?
I have knee pain.
Okay. And how long have you been experiencing this knee pain?
A couple days.
A couple days. Okay. So what we're going to do is we're going to take a series of x-rays of your knee. And then I just need to confirm it's your right knee that's bothering you.
Mm-hmm.
Okay. So if you'll follow me,
Okay.
I just need to get you shielded first. Okay. And then if I could have you lay down on the table. I'm going to lift this up a little bit. Okay, so my tube is detented at 40 inches, and now I'm centering my patient. I am centering a ½ inch below the patellar apex, and I'm going to collimate so that I include some of the distal femur and then the proximal tibia and fibula. And then also I'm putting my marker on there. So now I'm going to take the x-ray. Beep. Okay, so I've taken the x-ray. And now I'm going to come and do a medial oblique projection. Are you doing okay?
I'm great.
Okay, so for this next x-ray, I just need to rotate your leg in 45 degrees. So if I could just have you roll it in. There you go, that's perfect. And like I said, this is cassetteless. So if it wasn't cassetteless, I would be changing it out right now, but it gets sent directly to the monitor. So now all I have to do is just reposition. So I'm checking that it's still lined up with the bucky that's in here, which it is. And so now I'm just going to move it over slightly, and it's still a ½ inch below the patellar apex. And collimation can stay the same as long as I have in some of the femur, some of the distal femur, and the proximal tibia and fibula. Okay, and then also my marker. Okay, so now I'm going to go and take the next x-ray, which it's going to stay about the same for the technique, which is about 65 at 4. Okay. Beat, I've taken that x-ray, and so next I'm going to be doing the lateral. Okay, so now I'm going to be doing the lateral projection, and so what I would do first is I would come over, I would switch it to lateral, and then my technique would go up a little bit, so it'd probably be like 65 or like 5 or 6, nothing too crazy from the AP and the medial oblique. So I've already done that. So now I'm going to come back to my patient, and I'm going to give instructions to get into the lateral position. So if I could have you roll onto your right leg, and then have your left leg go back of you for support a little bit, and if I can have you flex your knee a little bit, probably about 20 to 30 degrees. And then what I would do is angle my tube slightly, probably about 5 degrees, and then also make sure that it's lined up with the bucky. So now I have to readjust it just because of the tube angulation. So now it's lined up, and now I'm going to move the table to get the central ray to about maybe ½ to 1 inch distal on the medial epicondyle, and then I'm going to put my right marker on. And then for this, she also needs to be shielded. So I'm going to just put this on her side, just to make sure that the breasts and the gonads are shielded. And then the collimation, I just want to make sure that it's collimated so that I get some of the distal femur and then the proximal tib bit. So my marker is down, and I'm going to go take the exposure. B. Okay, so that one is done, and then next I'm going to do a tunnel view and a sunrise. Okay, so now I'm going to be demonstrating how to do a tunnel view on the knee, which is actually called a PA axial intercondylar fossa, and I'm going to be doing home lab method. So I've set up my tube against the wall bucky this time, and it's at 40 inches, and then I'm going to have my patient lean up against the wall bucky. But first I'm going to shield, and I'm going to put this on backwards since the ray is going to be coming from the back of her. So if I can have put this on. Just need to lift it up just a little bit. And then if I could have you walk up to the wall bucky so that your right knee is at the center, and then lean up against it. Perfect, just like that. Okay, and I'm gonna place my right marker on here just so I know it's the right knee. And then I want to center at the, the back of the knee right here at the popliteal surface. And even though this is an axial, my ray is going into the wall bucky perpendicularly. She's just not standing up straight, so that's why it's considered axial. And I am going to collimate so that I get the same amount of tib fib and femur as the other views. And my marker just fell, so let me pick it up. Right there. And my technique for this is going to be probably the same as the AP, so it's going to go back to just 65 at 5. And then this is a DR system still, so I don't have to change out cassettes. When I take the exposure, it's going to go straight to the monitor and pop up. So that's what I'm going to do now. And next I am ready to do my sunrise, but that's it. Now I'm going to do the sunrise, which is the tangential projection of the patellofemoral joint. And the method I'm going to do is a set-a-gast. And just to save a little bit of time, I've already moved the wall bucky in my tube, and I positioned my patient. And I'm doing it with the wall bucky just because this is a DR system, so it's cassetteless. So the first thing that I'm going to do is shield my patient. Put this over you. And then since the ray is kind of coming up towards the gonads, I'm going to ask my patient to kind of shimmy it between her legs just to protect them. So if you could just kind of shimmy the shield to protect your gonads. Thank you. And so now if I could just have you, your leg is raised already, so that's perfect. Okay, so what I'm going to do is I'm going to get the central ray to enter about a ½ inch below the patella apex. So I'm going to bring this down just a little bit. There's going to be a little bit of OID. So let's see, right about there, you kind of want to see a U with the crosshairs, and it's going to throw the image up onto the wall bucky here. And I'm going to put my marker, my right marker on right about here. Okay, and the technique for this is going to be about 65 at 5. And now I'm going to go take my image. Okay, and that's it. And so then at this point, I've taken all of my images. I'm going to walk my patient back to the fitting room to get out of the gown and back to the waiting room. And then I will go over images with you. Now I'm going to go over some of the knee projections as far as the radiographs go. So this is the AP knee, and you can't see the patella because it's superimposed over the femur. And you can see the open joint space right here, and there is slight overlap of the proximal tibiofibular joint. And then for the lateral knee, which is this one right here, you'll see that the femoral condyles are superimposed. There's open joint space between the patella and the femur. And then for the tangential patella, that's this one right here. You can see this is the patella, and there's open joint space right here, which is what you want to see for that one. And then the next one is the medial oblique. So for this one, it throws the patella to the medial side, which is right here. And then there's open joint spaces, and then it also opens up the proximal tibiofibular joint space. And then for the last one, which is the tunnel view, the PA axial intercondylar fossa, it opens up the intercondylar fossa so you can see the intercondylar eminence. Usually that's a view done for ACL tears, and that's it.